to you all. I am Dr. Vasantha Kumari, IMA AMS Chairman Telangana. On behalf of IMA AMS Telangana, I cordially invite you all for today's webinar on organ donation awareness on the occasion of World Organ Donation Day with the aim of donate organs and save lives. This program is done along with IMA AMS headquarters. Organ donation awareness program is led by Jeevan team in charge of Dr. Swarnalatha and her team from NIMS and NIMS Hyderabad. Dr. Sanjeev Singh Yadav, member of Standing Committee of Organ Donation, will be joining us and he will be sharing the message from IMA headquarters. This time IMA, Indian Medical Association, has taken up organ donation program, and for, at the state level, national level and all the local branches level, we are going to conduct awareness programs on organ donation, and we have also prepared a pledge form and ID card for all the IMA doctors, those who are going to give the pledge forms. And today we are going to have three topics. First topic is Jeevan program led by Dr. Swarnalatha Madam, Professor HOD Nephrology Department at NIMS Hyderabad. And second topic is Declaration of Brain Death by Dr. Pawan, Assistant Professor, Neurology Department, NIMS Hyderabad. Third topic is Optimization of the Donor by Dr. Kavita, Additional Professor of Anesthesiology, NIMS Hyderabad. Dr. Sanjeev, have you joined? No. Dr. Kavita?
Yeah, I'm there.
Kavita.
I'm there, ma'am.
Yeah. I invite Dr. Kavita Reddy, Women Doctor Wing Chairperson of Telangana, to introduce Dr. Swarnalatha Madam. Over to you, Kavita. Kavita, unmute chesko. Hello. Hello, Dr. Kavita. Kavita, please go on.
Recording in progress. NIMS Hyderabad and in charge of jeevan program, Telangana State Government. Madam has fellowships, FRCP London and FISN, Fellow of Indian Society of Nephrology, Fellow of Indian Society of Organ Transplantation. Madam has many awards in her name. Tanker Award for paper, oxidative stress induced by IV iron therapy in hemodialysis patients, and role of N-acetylcysteine as an antioxidant. Travel grant for paper presentation on demography and clinical profile of end stage of renal diseases, held in Seoul, South Africa. Travel grant for paper presentation on early conversion to epimesis in renal transplant recipient in Berlin, Germany. And Madam has many publications nationally and internationally, and she is an associate editor of Postgraduate Nephrology 2011, Hemodialysis Manual 2017, and Manual of Transplant Coordinator 2018. And she is a guide of DM students in nephrology and PhD students. I welcome Madam Swarnalatha to this program. Thank you, Vasantha ma'am, for giving me this opportunity.
You're welcome, Kavita. I would like to take only 1 minute, Dr. Swarnalatha Madam. Thank you, Dr. Kavita. I would like to take only 1 minute, Dr. Swarnalatha Madam. When you have visited to Nalgonda for Jeevan program, we have collected more than 1,000 pledge forms by me and Dr. Kavita and Dr. Hari Sandhya Rani and other doctors from all over Telangana, 2019. So the program was conducted by National Women Doctor Wing Chairperson Dr. Mona Desai. We have on the whole national level Women Doctors Wing, we could collect more than 16,000 pledge forms on one day. And we were in the third position. Telangana was in third position. Thank you. Over to
Thank
you,
you, madam,
Dr.
for such
Swarnalatha,
nice
madam.
introduction. Yeah, thank you, madam, for taking such a great initiative on the occasion of Organ Donation Day. I really appreciate your team for coming forward to know about the organ donation status in our country and in our state, and bring the awareness about the organ donation in our medical fraternity. Thank you very much, madam. So I'll be talking briefly on this Jeevan program. What is the transplant organ donation and transplant status in the entire country? And then how our state as a Telangana is doing, and this would be followed by declaration of a brain death, which is the important part. I mean, which is the crux of this the whole of the organ donation process. Will be led by Dr. Pawan. He is a faculty at Nizam Medical Sciences, and it will be followed by donor optimization. I mean, one of the important challenges after identification of the brain death patient is optimizing the donor. Otherwise, we will end up losing the patient despite giving the consent on the declaration. So that will be led by Dr. Kavita. She is also our senior faculty from Nizam Medical Scientist from the Department of Anesthesia. So let me first share my slides. So my slides visible?
No, not yet, madam.
I'm trying to move my slides also. I mean, are you able to appreciate my slides moving?
We have seen the slides now.
Yes.
Okay. So I think India has achieved one of the landmark of crossing 15,000 organ transplantation in the year 2020. Among which 10,000 were the kidney transplantation, but the deceased donors were only 2,700 among the 15,000, and out of which 1,500 odd were the kidney transplantation. So this is one of the landmark achievement in India. But if you look at worldwide, maximum donation happens in the United States with around 42,000 to 800 kidney overall transplantations and 25,000 being kidney transplantation. So with these figures, the United States is number one in the entire world. But however, yeah, unfortunately, like we look at the Western world for the organ transplantation, but if you look at our own culture, Indian culture, we have so many examples, not the decades or the centuries. I think, a few lakhs of centuries called yugas before. We have, the slokas in Bhagavad Gita saying that the human body should be recycled. And then we have a story. I don't know, like how many people will appreciate. Can I just have a feedback what these stories are in our own mythology and in our culture? I'll just wait for a minute. If somebody can enumerate these stories or the shloka. I think I can see most of the senior people here, so I think they should be knowing all these stories. You know the story of Bibi Chakravarti. So he has donated his muzzle to some to save the life of a dove. That dove was being killed by the eagle. Actually, that was Shiva and Parvati took the form of a dove and evil to test the king Bibi Chakravarti. So the moral of the story is, human beings have donated their body parts for the mankind, and so also we know the Vajrayutham story of Vajrayutham, where Dadiji sage has donated his spine, for the formation of a Vajrayutham, which was used to kill the Asuras. So we are very rich in our own culture and heritage in terms of organ transplantation. Very, the famous god, Ganesha. So we celebrate the Vinayak Chauthi. I think August we have this festival around the corner. So we have so many examples, inspirational stories in our own culture, which inspires us about the organ transplantation. But unfortunately, we look at the figures from the Western world. So even in the modern medicine also, we have one of the examples. So for the first, I think the surgeon in India is the Shushruta, and his first surgery was nothing but a skin graft being done. So I think, we Indians don't have to look at Western world. We are very rich in our own culture in terms of organ transplantation. Now coming to the modern era, so I think first the transplantation in India was done in 1967. The cadaveric kidney transplantation came in Mumbai, In 1994, the heart transplantation was done in AIMS, and in 1995, the multi-organ transplantation was done in Chennai, and in 1998, the first successful lung transplantation was done again in Chennai. 1999, the first pancreas transplantation done. Coming to the Telugu speaking states, in 2002, the first cadaveric kidney transplantation was done in our own institute, that is Nizam Medical Sciences. That's about the history of deceased organ transplantation in India. But if you look at the statistics now, what is the demand? So you can see more than 2 lakhs people, they require kidney transplantation per year, and mind you, these figures increases every year. And around 50,000 heart transplantation, 30,000 being liver transplant. That is the requirement. But if you look at the donation rate is very minimal. As you can see, this is the donation rate is actually calculated in terms of per million population. The maximum being in Spain is somewhere around 50 per million population. Look at the Indian donation rate, it is actually less than 1 per million population. So how do you define the donation, organ donation? Basically, it is two types of organ donations available as of now. One is the living donation, wherein the family members, the close relatives of a person, deceased, a patient, whether it's a kidney patient, different liver, the family members can donate, maybe the brothers or the parents or the siblings or the kid.
Recording in progress.
Indian government, and subsequently in 1995 I did the Answan Andhra Pradesh government. Of course, there have been several amendments. The latest act which we use is 2014. That is the latest amendment. So there have been several amendments. I'm not going to detail because legalities itself take a lot of time. So what I can just suggest is it's available freely in our website. You can just go to our website. So I mean various the procedural aspects of organ donation in terms of as well as the disease zone transplantation, and what are the rules and regulations and the licensing of the hospitals, and also the penalties when we violate these rules and regulations. Everything has been covered in this act. Now coming to India, basically it is all restricted to, as you all know, India is a diverse culture, and so also is applicable to organ donation, particularly with respect to disease donor transplantation program. It is basically in the southern part of the India where the maximum donations, particular disease donor transplant, are happening. The green is the maximum donation. As you can see, Chennai is one of the number one in terms of disease donor transplantation program. So coming to our own program, how it has evolved over a period of years. It was first started in 2010 with Answal, Andhra Pradesh, and then we had a unique challenge of the division of the state in 2014. Initially, we have worked on developing this program in Answal, Andhra Pradesh, but after division, we are just taking care of it in Telangana, and as you can see, there has been a dramatic, improvement in the program. As it was like localized area, and there more focus, and with more availability of the expertise, in particularly focused in Hyderabad, so we could grow the program, and we have actually crossed a landmark of 1,200 donations recently. So as you can see, over a period of years, it has gradually increased from 41 donations in 2013 to 2022. We had 194 donations, which is maximum in the entire country for the year 2022. And overall, we have 1,200 plus donations. So as I said initially, there are around 15,000 transplantation occurring in India in both disease and live transplantation. This is the maximum which I have recorded for the past 1 decade. When it comes to last year, 2022, as you can see, Telangana stood number one in the entire country with 655 overall transplantation, followed by Tamil Nadu 553. Once upon a time, it was said that Tamil Nadu is number one in the entire country in terms of the transplantation.
Though we have been late from compared to Tamil Nadu, we have overtaken, we have surpassed them, and we are now number one in terms of organ transplantation. It is followed by Karnataka, Gujarat, and then the Maharashtra. So as I said, we had last year we had 194 donations deceased from the deceased donor, and we stood the number one in the entire country. So our this slide I have shown previously comparing the overall donation rate in the entire world, and the Indian donation rate, it was only minimal of 0.5 parts per million. But look at the Telangana donation rate, it is 5.5 parts per population. So it's a country. So how all to become, the number one in the entire country. So I think we have to look at the aspects of organ disease donor organ transplantation, particularly with respect to various stakeholders. So topmost is the government support. So Jeevan is a government platform. It is a government program wherein we have provided a platform where we maintain a registry for all the recipients, and we also try to regulate across the entire state in terms of licensing the hospital, in terms of creating the awareness, in terms of training the various stakeholders, including the transplant coordinators, and then training the intensivist and the neurologist and neurosurgeon in terms of organ declaration and optimizations. So I think we have dealt with all these things, and that's how we have tried to evolve as a number one in the country. I'll just try to briefly discuss all these points in subsequent slides. So this is how we have evolved. This is the time chart. So from 2010 we have got the GO. So we have started working with that particular GO. We had several meetings with the stakeholders, particularly with respect to the policy makers as well as the medical fraternity. So we had advisory committee meeting, and subsequently in 2012 we have come up with the guidelines for the organ allocation. The scientific committees, that is liver and pancreas, and we had a kidney committee, and we had a then heart and lung subcommittee. We had a neurology and a committee of neurology neurosurgeons. We had a committee of forensic people. So all these committees, they sat together with the guidelines, and then 2012 and 2013 we have formed an organ allocation guidelines, and this will all translated into a web portal. So again, this is I think one of the important feature of our program is we had the online allocation policy. It was the first. Our state was the first to come up with such a robust online allocation policy. So I think this has built up a confidence in the public as it is transparent and an equitable distribution based upon the scientific committee's recommendations. And 2015. So another myth is that it's not available. Transplantation is very costly. It is not available for a common man. It is only available or accessible for rich people. The government has taken an initiative, and it was all the transplantations were covered under the Arogeshri program, including the heart and lung transplantation with a package of 12 lakhs, and liver package of 9 lakhs, and kidney transplantation package of 2.5 to 3 lakhs. And in 2016 and 17, we have realized that most of the brain deaths are occurring from the road traffic accidents, particularly with head injuries, and going on to develop a brain death. So again, there was difficulties, challenges for us to mobilize the police people. Police were again confused that usually they are involved once patient is declared dead, and then they hand over the body to the police, and then police will hand over the body to a forensic people. They do the post-mortem, and then again hand over the post-mortem report along with the body to the police person. So we had a difficulty in calling the police people to the hospital. And they used to come and they see that BP is there, and the patient is connected to monitor, and when ECG recording is there, and patient is put on ventilator. There's a lot of confusion among the police, but the patient is not dead. Then we had a series of meetings with the police people saying that it's a brain death, and second declaration of brain death should be considered as a death. And we have formed various guidelines for that also, and we have discussed this with the police training, the level of training, and that's how we have tried to streamline. Again, forensic also had a committee meetings, and forensic people, they were mobilized and they were asked to do a postmortem, not in the Usmania Gandhi hospital, but in the hospital where donation with the police, call them, time of organ, they come, they do their respective duties by conducted the inquest, in the postmortem, they do not give findings which required, and they once the trial is over, they try to do and they itself and hand over body to families. That's how we have streamlined even the police and forensic part. And of course, in 18 and 19, we have initiated an innovative program called Condolences Program. We started going with the donor family to their village. We conducted all the last rites and then the rituals along with them. And we tried to project them as one of the hero, and we tried to simultaneously pass on the message to the fellow villagers that they have done a very great job by donating the organ. It is a lot of awareness has been created in the village. And of course, we had faced all the world has faced with the unique challenge of COVID infection, COVID pandemic, and all walks of life were affected, including our the healthcare system and our organ transplantation program. But however, we have tried to learn during the crisis also. So as you can see and we can appreciate that lung transplantation has picked up after the COVID period, and most of the patients across the India, they were airlifted to Hyderabad, and Hyderabad was one of the hub for the lung transplantation. And now we are trying to move to our to a national level to go to the National Organ and Tissue Transplantation Organization. So we are trying to connect at a national level and a district level, so trying to expand in both ways, and that's how we are trying to grow. And of course, we have evolved as number one. So these are the milestones. Depending upon the timeline. So I just the same thing I have represented in terms of a few of the photographs. This is the geo which we have started our journey in 2010. That's called Jeevan. Itself is named as the Jeevan. And as I said, organ allocation policy was the most important aspect, because we need to have equitable distribution of the organs, which is well utilized. Not like we are transplanting an organ from a very young patient to a very elderly patient whose survival is very less, or whose the general condition is very poor. So they should be optimally utilized. But again, everybody should have equal access to the the organ, whether it's young or old. So we have tried to have this balance with organ allocation policies. So these are okay. So these are these few of the allocation policies which was developed by the committee: kidney, liver, and heart and lung, depending upon the blood group, the size match, the age match. This is the portal which we have developed through NIC National Informatics Center, and this portal has become one of the role model for the other countries also. Our different states, including Karnataka, Kerala, and then Gujarat, Bhubaneswar, and now the Lucknow, and then Jammu and Kashmir has also approached us in having this software being shared with them. So this is our software. This is the mobile app wherein people can try to brush their organs through a mobile app. This is the best award which I have got in 2015 and again 2020 for the best software, and then the smart governance award. And this is how we try to. One of the important aspect of Jeevan is regulatory. It's a regulatory authority. We try to enable the hospitals, give the license, and then we also help them in creating their own protocols, and then building their own teams, and then we are trying to give permission as organ transplantation centers. Before Jeevan, only 50 hospitals we were doing organ transplantation, particularly disease zone transplantation. Now we have 37 hospitals who are doing the organ transplantation. These are the few of the programs which we have been trying to train the medical fraternity in terms of winner declaration and optimization. These are the 37 hospitals which are a part of our Jeevan program. And I said we are trying to train people also who are the stakeholders in this. One of the important people being the coordinators, because these are the people who try to go and talk to the family member, counsel them, and convince them for the organ donation during a very a difficult state where they're trying to lose their loved ones and they're emotionally very much disturbed. So there's no structured program in any of the universities. So we have tried to come up with our own certificate program. So it's 1 year program with 60 hours of teaching program. We try to cover all various aspects of organ transplantation which a coordinator should know. So these are one of such programs, and we try to give certificate at the end of the program as well. So these were the meetings with the police people. We are trying to convince them that the Pachnama has to be done at the hospital. And not only that, the inquest part, they have also been very helpful in creating the green corridors, and then in counseling the family members as well. So they have sent a circular to all the police stations, And there we have conducted various awareness programs for the police people, and that's how we could succeed in sensitizing the police person as well. So this is how we get a help from the police people creating a green corridors. So this is what is the Arogeshri packages which has been included, and wherein where people below poverty line with Arogeshri cards are accessible to the organ transplantation. And that's how we could transplant around 400 plus patients in all the three government hospitals, including the kidney, liver, heart, and lung transplantation. So you can't imagine, the transplants like heart and lung can also be done in government hospital. I think this is one of the best hospital in government sector which is doing the organ transplantation. So forensic also recently you might have seen in the newspaper that central government has passed an order saying that the postmortem can be done after the sunset also. But we have started doing this in 2013 itself, and through this jeevan program. So there are a lot of myths, particular religious myths are there with respect to organ donation. We are trying to address those also. Trying to meet the religious scholars and trying to convince them and trying to sensitize them, and through them we are trying to approach their own community. And then we have started getting donations from all the communities where they had a myths. So these are the few of the honoring programs we conduct regularly to all the family members who have donated the organs. And we have been creating awareness in the public through various celebrities or influential people, including the police and then movie artists. This is a continuous process. We have been conducting various awareness programs like runs and walks. And this is one such initiative of increasing the awareness among the public, particularly next generation, by putting this into even in textbooks. So now, if you can see, I mean, your kids might have been undergoing a 10th class, or your granddaughters or grandsons. You can see it's there in the 10th class biology textbook where we have talked. The state chapter has talked about the organ donation, and not only organ donation, it has talked about the brain death and then the jeevan program as well. So these are the condolence program which I was talking about. We try to go to the family go to the village along with the family members during their rituals. We try to honor them, and if possible, we try to mobilize the local leaders also, so that we are trying to acknowledge the family members for a very generous act of accepting for organ donation. At the same time, we are sending a message to the poor villagers that they have done a very good job, and it has to be done whenever it's possible. These are the few of the clippings showing that attending the rituals along with this patient was the donor was a police people. So even police had come to perform the the last rites. As you can see, it was well appreciated by everyone. As I said, we are trying to network with the national level NOTO, SOTO, and ROTO. ROTO is we have 5 ROTOs. So all the southern states are under the southern ROTO, that is in the Chennai. And through ROTO, we are connected to NOTO. So we have the organ sharing protocols also. Whenever we have organs within the state and it's not being utilized, we send an alert. Beyond the state through ROTO, and organs are. That's how the organs are utilized and not wasted. So most of the times, as our program is robust, we are trying to accept most of the organs, particularly with heart and lung, not being accepted anywhere in India. So, this is what recently 3rd August. So 3rd August is actually conducted as an organ donation, National Organ Donation Day. As I said, if you remember in the initial slide I showed, the 3rd August, the first heart transplantation was done in India, in New Delhi. So that's the reason why 3rd August is declared as the Organ Donation Day in India. So 3rd August, one of our representative, Dr. Padmaja Madam, she is the anesthesia professor. She went to receive the award from the NOTO, from Jeevan state, Telangana state, and Madam has received an award, as you can see here, from the national body. So this is how we have evolved, but I think there is a lot more to travel, and there is a very long way forward. Because there is a lot of, still there is a gap between the requirement and the donation rate. So still we have around 3,000 people being registered in the Jeevan waiting for various organs. These are only registered, but there are so many people not registered and still waiting for the organs. So I, being a nephrologist, we are doing the dialysis, and we are being connected to all the peripheral dialysis centers through hub and spoke models, and we have 10,000 people on dialysis in the state of Telangana. And I think all these patients who are on dialysis are eligible for the transplant. That is the burden of the kidney disease, and the similar burden is also seen in heart and the liver transplantation. I think there's a long way to go. We need to come together to bridge this gap, particularly with respect to knowledge gap. We have to motivate our own medical fraternity. Being a doctor is our responsibility to make ourselves aware of the advancements in medical practices and also make aware of the public about the organ donation and bridge the gap. Thank you, madam. Thank you for providing the opportunity. I have a few more statistics, but I don't want to cover those statistics because I think in 20 minutes right now, I just want my colleagues also to talk about the organ optimization and the organ declaration. Thank you. Thank you.
Thank you. Thank you, madam. I invite Dr. Hari Sandhya Rani, IMA Women Doctor Wing Chairperson, Warangal, Principal, Father Colombo Institute of Medical Sciences, Warangal. Over to you, Sandhya. Please introduce Dr. Pawan.
Good evening, everybody. I'm Dr. Sandhya from Warangal. Actually, 2 years back, that is 2019, we have conducted an organ donation campaign in our Warangal. The rally we have done on 9/8/2019, and rally we have taken from MGM Hospital to the Kakatiya Medical College, and we had a good speakers and chief guest as Manjusha Madam from Gandhi Medical College, and other speakers Priti Reddy from NIMS and Banuchandra from Usmania Medical College, and we had a good speakers, and we have felicitated 5 members of the candidates, the families of the people who have donated the organs. So this we have done it 2 years back, and all the medical students, nursing students, and the public people, they have participated in this program, and we have collected the forms from the public for their willingness to donate the organs. Now I am privileged to introduce Mr. Pavan Kumar Panam, and he is born in 25/8/1990, and he is 32 years male, and his father is N.I.D. Rao P, and his wife is Haimavati Akula, MD Emergency Medicine, working as a senior resident in NIMS. And his MBBS details, he is passed out from PIMS, Gannavaram, AP 2018 8 to 2014, and he is in General Medicine in Ashram Hospital, Elur, from 2015 to 2018, and he is doing DM Neurology in NIMS, Panjagutta, Hyderabad, 2019 to 2022. And his experience is now he is working as assistant professor contract basis in NIMS Hospital as a part of my bond service for 2 years. He worked as senior resident for 1 year in Ashram Hospital, Eluru, after completion of MD conferences. He has attended Apicon Mumbai in 2016 and Mumbai Update in Neurology in 2023. Thesis and publications, demographic, etiological and investigational profile in acute symptomatic seizures at tertiary care hospital. A role of vessel wall imaging in young ischemic stroke patients. Now I will present Dr. Pavan. I am very glad to hear his lecture. Thank you very much.
Ma'am. Am I audible, ma'am?
Yes, sir.
Is my screen visible, ma'am?
Yes, sir.
Yes.
Thank you to the IMA team for giving me this opportunity, and thanks to Dr. Swarnalatha ma'am and Dr. Jeevan ma'am for giving me this opportunity to present in this session. Coming to declaration of brain death, today, ma'am, my screen is visible, ma'am?
Yes, sir.
Yes.
Today, my talk includes definitely.
Dr. Pawan?
Ma'am.
Not in a slideshow mode, so make it slideshow mode.
Yeah. Is it okay, ma'am? No?
Yes.
Today, my talk includes definition of brain death and prerequisites before going to brain death, and main talk includes clinical examination including apnea test and ancillary test when we are unable to do apnea test, and brain death declaration finally. So coming to definition of brain death, initially US President's Commission report on guidelines for the determination of death. In Uniform Determination of Death Act, they gave the definition of death like irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. They didn't conclude the definition of brain death initially, but in 1995, American Academy of Neurology, they delineated some with the medical standards. They defined the brain death definition in terms of three clinical findings necessary to confirm the irreversible cessation of all functions of entire brain, coma with a known cause, and absence of brainstem reflexes, and apnea. So I want to say that brain death is a clinical determination, and it includes clinical examination in the form of absence of demonstration of absence of brainstem reflexes and absence of motor response to deep painful stimulus, and confirmation of positive apnea test. So before going to do clinical examination, there are many confounders to do brain death declaration. So first of all, we have to rule out all these patient not on all these. Like we have to check the temperature of, if it is less than 32 degrees, we have to take the action in order to correct the hypothermia. So to the level of 36 degrees centigrade. Any sedatives or any paralytic drug. If patient on sedatives or paralytic drug, we have to wait for the until the 5 half-lives to go off. That by that time only we have to go ahead with the brainstem declaration. And when anytime patient on hypotension, we have to maintain the systolic blood pressure of more than 100 mm of Hg, either with or without inotropes or vasopressor support. And when severe acid-base disturbance also we can correct in order to maintain the arterial pH of pH 7.35 to 7.45 and PCO2 of 35 to 45 mm of Hg. Based on ventilatory settings, sometimes it is possible to correct the acid bed disturbances in order to maintain the PCO2 level predominantly. And oxygenation level must be definitely good. We have to maintain the PO2 level of 100 mm of Hg by going ahead with the pre-oxygenation with FiO2 of 100% on the ventilator settings. So after ruling out all these confounders and to make a normal levels only, we will go ahead with the clinical examination of brain death declaration. So it includes predominantly brainstem reflexes. So it includes examination of pupils. So first of all, we have to check the pupillary size, whether there is a pupils are either dilated or mid-dilated or fixed, or pupils are constricted. So whenever pupils are constricted, it is not one of the red flag in declaration of brain death. We have to rule out any patient on any sedative drugs or any toxication under patient under intoxication. We have to rule out by sending the serum levels. That time we won't go ahead with the brain death declaration. So either pupil has to be dilated or completely dilated to the size of 4 to 9 mm. And absence of pupillary light reflex on both sides. So coming to corneal reflex should be absent. We have to touch with a thin cotton swab on both cornea, and we have to observe for any eye blink response. So generally in brain death patients, the corneal reflex must be absent. So coming to extraocular movements, it includes both either any spontaneous roving ocular movements or any nystagmoid movements or spontaneous nystagmus eye movement or any conjugated deviate eye movements we have to check for before going to extraocular movement examination. So any spontaneous eye movements, any nystagmus or any conjugate eye deviation to one side, we won't declare that as brain death. So whenever that is not there, eyes are fixed in fixed position without absence of any extraocular movements, that time we will do any oculocephalic reflex and oculovestibular reflex. Oculocephalic reflex includes, it is like doll's eye maneuver only. Suddenly we will shift the head on horizontally on both sides, either towards the right side or towards the left side, and we have to check for the any opposite horizontal ocular movements we have to examine. Generally vertically we won't do commonly. Horizontal is enough to check for the oculocephalic reflex. And coming to vestibular ocular reflex, either we can connect to any suction catheter with the 50 ml syringe, or we can directly include the ice water in the 30 to 50 ml syringe. We will flush the the ice water into the end of the auditory canal. Before that, we have to rule out any tympanic membrane rupture. But in order to don't introduce any infection during that time, so before doing caloric test, we have to check the patency of the auditory canal, and after that we will go ahead with caloric test, and we have to observe for a minimum of one that has no response, and there is an interval of 5 minutes between the both ears. So generally we will do with the cold water commonly. So absence of vestibular ocular reflex we have to demonstrate. So coming to gag reflex or cuff reflex, in for this test we have to stimulate the either posterior pharyngeal valve with the cotton swab or tongue depressor, and we have to see for the any gag response or movements of the tongue or movements of the jaw or movement of the jaw or any pharyngeal musculature movement we have to observe. Or coming to cuff reflex, we have to stimulate the tracheobronchial valve with the suction catheter up to the carina, and we have to stimulate that and to see for any cuff response by the contraction of diaphragmatic muscles. So we have to do these two tests also. So if you observe clearly, all this includes cranial nerve reflexes related to brainstem. Reflex difference includes second and third cranial nerve. It includes fifth cranial nerve and uh, extraocular movements in 3, 4, 6. We are assessing the 3, 4, 6 cranial nerves, and also 8th cranial nerve we are examining. 9th and 10th cranial nerve reflexes are gag and cough reflex. To say the brain dead, first of all reflexes should be absent. And coming to motor response to deep painful stimulus, uh, here we will get some difficulty when we are demonstrating this motor response test. Here we have to observe for both facial response and facial stimulation and total body other body area stimulation at the area of temporomandibular joint condyles and supraorbital notch, fingernail beds, or sternal rubbing. And we have to assess for any grimacing or to the deep painful stimulus, any decerebrate posturing or decorticate posturing whenever we are demonstrating the motor response test. At any time these grimacing or these posturings are positive, the patient we won't declare that as brain death. So there are some of the spinal mediated reflex we will observe when we are doing the spinal mediated reflex, because the blood supply sparing to the rostral portion beyond the C2 spine. Whenever we are doing the brain death declaration, we will this false positive test. So those who are trained in the brain death declaration that time, otherwise it is very difficult to conclude. We have to depend on the ancillary testing other than clinical examination. So this undulating toe flexion response, triple flexion response includes flexion of the thigh, leg and foot. This is the one of the commonest spinal mediated reflex we will see. The plantar flexion response, or pronator extension reflex, quadriceps flexion, facial myokymia. The Lazarus sign also we will see commonly when we are doing whenever we are disconnecting the patient from ventilator, and whenever we are doing apnea test, whenever patient had any hypoxia or hypotension during the time of apnea test, we will see the Lazarus sign commonly in the form of bilateral arm flexion, shoulder adduction, and hand rising to the chest or neck, which is either triggered by sternal stimulation or head flexion movement or doing the apnea test also. This is also one of the commonest spinal mediated reflex we will see commonly. And myoclonus of the arm or leg or muscle fasciculations, and spontaneous movements of the limb or respiratory like movements. This also we have to see any shoulder elevation and adduction movement with intercostal expansion without the significant tidal volumes. This we will take that as false positive not there, as patient chest movements are there, but these chest movements are very shallow. This won't create any tidal volume, but they are not actually original chest expansion that that creates the tidal volume. And also we have to observe for we will see the other response like tachycardia, normal blood pressure without any pharmacological support, and the changes of blood pressure, and absence of diabetes insipidus, and presence of any deep tendon reflexes or superficial abdominal reflexes. All these we will see as a spinal mediated reflexes. If you observe all these are all below the foramen magnum, that including the limb movements, extremity movements, or chest movements or abdominal movements we are seeing. In these situations, doctors are facing difficulty in concluding the brain death because of that movement, spinal mediated reflexes. So those who are expertise in doing the brain death declaration, it is very easy to go ahead with the apnea test, even though these movements are present. And coming to apnea test, I already told after ruling out all confounders before doing going ahead with the apnea test. So we had some fear while doing this apnea test, but it is all the prerequisites meets. It is very easy to do, and confirmation of apnea test is very easy. And before doing apnea test, we have to pre-oxygenate with 100% oxygen for at least 10 minutes, and we'll go ahead with ABG, and we check for the PaO2 levels and PCO2 levels. PaO2 levels minimum of 200 mm of Hg, and PCO2 of 35 to 45 minimum mm of Hg, and with normal pH. And BP systolic blood pressure of 90 to 100 mm of Hg, with or without inotropes or vasopressor support. So how we will do apnea testing? Either we can connect the by using the method of oxygen insufflation method by placing the tracheal cannula up to the carina level, or else we will shift the patient to CPAP mode on the mechanical ventilation itself, or we will connect the T-piece, and with the T-piece we will connect the resuscitation bag. It includes a CPAP valve or PEEP valve. So coming to procedure of apnea test, after disconnection from the ventilator, we have to provide the oxygen via suction catheter to the level of carina. Oxygen 6 liters per minute. We will do continue for the apnea test for a minimum duration of 8 to 10 minutes, and we have to observe for breathing efforts. It includes any chest movements. So positive apnea test includes pH of less than 7.3 and PCO2 of 60 mm of Hg, or increase of 20 mm of Hg from the normal baseline PCO2. The logic behind this was whenever any patient medullary function was intact, to the change of PCO2 pH and to the change of PCO2, like that is any acidosis or any hypercapnia, will stimulate the medullary centers, that resulting in chest expansion movement. Whenever patient had brain death, there is no stimulation of medullary chemoreceptor, and there is no response to acidosis or hypercarbia. So I will show the two examples what we did in the NIMS hospital. So this is the first ABG. Here, if you see the pH of normal, pH within the normal range of 7.35 to 7.45, and PaO2 of 211 and PCO2 of 35, and with a FiO2 of 100%, we did the apnea test of, for 8 to 10 minutes. After disconnecting from the ventilator, we repeated the ABG. CO2 rise pH 35 to 57. So there is more than 20 rise of PCO2. With that PCO2 rise, there is decreased pH of 7.20. So there is no chest expansion movements demonstrated, and we declared that this test as apnea test was positive. So these two parameters we have to check for PCO2 rise of more than 20. With that rise, the decreased pH in acidotic range we have to see. This is the other test. This pH is not that, PCO2 is not that much range 32, but even though we 35 to 45 normally we will see, in some circumstances we will do even all other on all other clinical examination parameters are cooperating for the apnea test. PCO2 from 32 to 53, so there is rise of 20 mm of PCO2 rise, and pH also from normal 7.35 to 7.45 range to acidotic range 7.26. So patient had no chest movements. That time we concluded that apnea test is positive. So finally, whenever we are doing the apnea test, we will face some of the problems like it is either positive or negative, inconclusive or aborted. Coming to inconclusive means even after 8 to 10 minutes of the after 10 minutes after disconnecting from the ventilator, sometimes we won't rise there is no rise of more than 20 mm of PCO2 and no pH change. That time we will repeat the test after adjusting the ventilator settings, and that is the one situation we will face. That time it is inconclusive. We will repeat the test after some time, and sometimes we have to abort the apnea test in situations like whenever patient oxygen levels are falling and patient systolic blood pressure is falling. That time we will abort the test and we will connect to ventilator. And here we have to remember one thing: if patient had decreased saturation or decreased BP levels a time of 5 minutes, that time we will go ahead with ABG. If that ABG showing increased rise of VCO2 of more than 20 and pH of acidotic range, we will conclude that test as apnea test as positive, even though we didn't do the test for 10 minutes or 8 minutes duration. Uh, so whenever we are unable to conclude the apnea test positive, we will depend upon the ancillary tests during that time. So generally we will go ahead with ancillary tests in situations like whenever we will finally conclude that tests like brain death, brainstem reflexes are absent. Whenever we are unable to conclude the situation, unable to find out the situation like this, like whenever patient had severe facial trauma, or whenever patient has severe conjunctival edema, or some situation we are unable to conclude the test, or at that time we'll go ahead with ancillary test. And sometimes apnea test will go ahead with inconclusive apnea test. That time also will depend on the ancillary test. uh, that time we will go ahead with the ancillary test. It includes generally we will avoid the ancillary test, and to the clinical extent possible, maximum as possible will depend on the clinical examination only. So coming to ancillary test, one is demonstration of complete absence of brain blood flow by doing extra subtraction angiography, CT angiography or MR angiography, or else a transcranial Doppler ultrasonography or radionuclide studies. Generally in NIMS we will follow the CT angiography or MR angiography with contrast. Demonstration of absence of cerebral circulation beyond the skull, from the skull vault. It is the one of the positive test with the CT angio, MR angiography or digital subnet angiography. So coming to the right side, right normal CT angio picture, we are demonstrating the intracranial cerebral circuit. To left side image, we are seeing only extracranial carotid system. We are unable to seeing the circulatory system because of raised ICP. No, ICP is very high, so that there is no brain stem circulation. Brain circulation. We didn't establish any circulation. This test we take this as a positive test of CT angiography. So if you see clearly, this is the right side normal CT. We are seeing the gyrus sulci clearly. This is the same patient what I saw previously, that CT angio. This is, we are unable to see any gyrus sulci. Complete diffuse cerebral edema we are seeing, secondary to rigid ICP, not allowing any blood flow to the brain. Coming to transcranial Doppler ultrasonography, we will demonstrate the biphasic oscillating flow and the systolic spikes with reversal of flow in diastole. With this finding, we will conclude that as uh, transcranial Doppler brain death confirmation. And radionuclide studies absence of intracranial isotope, that is empty skull, we will demonstrate by using radionuclide studies. Out of these three, we are daily whenever we are facing problem with the apnea test, we are going ahead with either CT angiography or MR angiography contrast. And coming to EEG, whenever in any situation we are unable to do CT angiography because of shifting the patient to the CT room, that time we will do the bedside EEG test. A minimum of 8 scalp electrodes should be used with a distance of 10 centimeters between the electrode, and the sensitivity should be increased at least 2 microvolts for minimum of 30 minutes duration. So there is no, that is called electrocerebral silence. So there is no brain activity. We have to confirm by doing EEG testing, and also EEG should demonstrate lack of reactivity to either some intense somatosensory or audiovisual stimuli. Previously, we will depend on the EEG for confirmation of brain death. Nowadays, we are using less commonly whenever only unable to do the apnea test or brainstem reflexes confirmation. That time only we are doing. We are depending on the EEG study. Along with EEG, we will do somatosensory evoked potentials or auditory evoked potential. So complete options of bilateral somatosensory evoked potentials or auditory evoked potentials. Along with the EEG, we will do the both test for confirmation. After confirmation of brain death, the signatures has to be signed by the medical board. A board of medical experts. There are 4 persons are involved in this. One is medical superintendent of the hospital, and the second one is authorized specialist, that is uh, already appointed by the medical superintendent of the hospital. Either he may be physician, general physician, or general surgeon, or anesthetist, or duty in charge of that ICU, or neurologist or neurosurgeon nominated by the medical superintendent. Fourth person was the doctor under whom the patient was admitted. Amendments in the Transplantation of Human Organ Act allowed the whenever neurosurgeon or neurologist was not available, surgeon or physician or anesthetist can confirm the brain death. So already this part is covered by ma'am. Ma'am. In all hospitals, all hospitals in the state have operational theatre and ICU. Those are registered under non-trans. They have having permission to certify the brain death, but they are not permitted to perform the transplantation. After confirming the certification of brain death, they have to inform to Zonal Transplantation Coordination Committee. The doctor who is participated in the brain death, they are now connected to the transplant surgeries concerning with the brain death cadaver. So this is the Telangana state brain death, brainstem death certificate. These are the patient details and hospital details, and diagnosis what patient is suffering from. All this what I already told. Like after ruling out all confounders, and we will demonstrate the options of brainstem reflexes, and we'll go ahead with the app test. And after apnea test, coming to apnea test, generally we are doing 2 times apnea test with a gap of 6 hours in between the test. After the confirmation of apnea test as positive, it was signed by the, already I told, the 4 persons are involved in the confirmation of brain death, a medical superintendent and authorized specialist, that is appointed by the medical superintendent, neurologist or neurosurgeon, and medical officer of the treating patient, who is treating the patient. So take home message was proper clinical examination and apnea test. Whenever unable to do the apnea test, plan for ancillary test, either it is CT angio or brain angio, preferably CT angio or EEG. Thank you.
Thank you, Dr.
Ma'am?
Pawan. We'll take question answers in the end at the end of the third topic also. Now I request Dr. Lingamurthy sir to introduce Dr. Kavita. Dr. Lingamurthy sir is a senior member of IMA. He is an anesthetist and is also a director for CGP IMA Telangana. Over to you, Dr. Lingamurthy sir.
Thank you, Dr. Vasantha. I am pleased to introduce the next speaker, Dr. Kavita Jairam. She is the additional professor, present designation, and affiliated to Nizam's Institute of Medical Sciences, Hyderabad. And coming to her experience and clinical interest, expertise, she has more than 10 years of teaching experience and special interest in regional anesthesia, intensive care, airway management, and statistics. Coming to the honors conferred on her, received Young Anesthesiologist Award of Telangana, great. Then Best Junior Faculty Award from the Institute, and invited faculty in many national and state conferences, have more than 25 national and international publications, And I welcome Kavita. The time is yours. Go ahead. Thank you.
Thank you so much, sir, for the kind introduction. I would like to share my screen.